All right, thank you, Dr. Khalili, Dr. Dougan, for two fantastic talks. They are both, our two experts are here for our Q&A session, and I think we'll just jump right in. So, Dr. Khalili, first question here, do you use fecal calprotectin in your practice to differentiate microscopic colitis symptoms from IBS?
I think in terms of making a diagnosis of microscopic colitis or IBS, I typically don't. I use biopsies, which are gold standard. I do at times check stool calprotectin at the time of diagnosis and look to see if I can use that as a way of monitoring response to treatment. And I do appreciate that there are patients who have overlapping symptoms of microscopic colitis and irritable bowel syndrome. And I think in that setting, assuming that their calprotectin was elevated at the time of diagnosis, it could be used as a way of differentiating. Having said that, vast majority of the time I end up repeating the colonoscopy to confirm that they don't have persistent microscopic colitis versus symptoms of IBS.
So just to follow up a quick clarification on that, so is fecal calprotectin reliable to use in microscopic colitis or not?
No, I mean, most studies have shown that, unfortunately, it's only elevated in probably somewhere between 40 to 60% of patients. You do find some patients that have really astronomically elevated calprotectin in practice, and I think those patient populations, it may be beneficial to monitor it, but vast majority of folks, or at least a good proportion of individuals, won't have elevated calprotectin.
Okay. Another follow-up question here about therapy. Is there a role for bile acid sequestrants in treating microscopic colitis?
Yeah, so in my practice, the way I use bile acid binder is primarily in combination or conjunction with other therapies, particularly budesonide. And so there are individuals who either have partial response to budesonide, or you may have difficulty tapering them off of budesonide, meaning that, as soon as they get down to 3 or 6 milligrams of budesonide, they have, some mild symptoms. And so in that sort of specific group of individuals, I try to add clostridiol to help them either get off budesonide or get them to a lower dose of budesonide that they can stay on, or they can sort of sustain remission on that lower dose of budesonide. So that's primarily the way I've used bile salt binder in treatment of microscopic colitis.
All right, great, thank you. Dr. Dougan, do you ever use PO budesonide for less symptomatic patients with checkpoint inhibitor colitis?
So I don't do it based on symptoms. I make the decision based on the endoscopic findings. So we now have a bunch of data from multiple different centers that the severity of the symptoms don't really track well with where the inflammation is or how severe it is. And for the more severe cases, budesonide doesn't really work. We actually have the only randomized controlled data for ICI colitis was a trial of budesonide, and it failed in that setting. But it does work in a setting where you select patients based on the severity of inflammation. So those with microscopic colitis, I use it all the time. Most of them, about 90% of them, will respond to budesonide and will not need systemic steroids.
Okay, great. And then, so there's a question here, Dr. Dougan, about the timing. And so I guess this is a question about the timing about when you initiate checkpoint inhibitor therapy and when you expect the colitis to occur relative to that.
Yeah, so there's really a lot of variability in that. If you look at patients on ipilimumab or ipilimumab combinations, it's really between dose 2 and dose 3, which is sort of somewhere in the 2 months range is about when patients wind up with colitis, although they really can have it at any point during the treatment course. There's a much broader interval for people on single agent PD-1 or PD-L1 blocking agents, more like somewhere between 6 weeks and 12 weeks, but it honestly can occur at any point. So think about it a lot in the 6 to 12 weeks, but I've seen patients who present with their first symptoms 2 years after they started therapy. So it really can occur at any point. It shouldn't be off the differential just because it's outside of the window that I just gave you.
Okay, great. So Dr. Khalili, this is a question about is there data for immunomodulators for treatment of refractory microscopic colitis?
There is some data for use of methotrexate. It's not really randomized data. It's primarily a case series published in Europe where methotrexate was shown to be effective in inducing remission. So I have used methotrexate at time in a subset of my patients who really have failed all biologic therapy, or they prefer to take an oral therapy as opposed to an injection or infusion.
Okay. And this is sort of a case of a very extreme case. So this is someone who has collagenous colitis, has failed conventional therapy, Entyvio and Remicade up to 10 mg per kg. What would you try next? Stelara, or would you consider diverting ileostomy?
So unfortunately, not that uncommon in my practice to see this. So a lot of it depends on the severity of their symptoms. I think if they are having very severe symptoms to a point that they're getting hospitalized, or to a point that they, it really affects their quality of life, I would consider JAK inhibitor in this individuals, in particular UPA or Rinvoq. I think has very good sort of a number of case series in individuals who have had very refractory disease, have responded well to JAK inhibitors. In terms of ustekinumab, yes, I've used it in several cases, and to be frank, I haven't had much success with use of ustekinumab. Biologically, it does make some sense, and there have been a number of case series where folks have tried ustekinumab with success. So I think it's totally fine to try either ustekinumab or JAK inhibitors. In terms of diverting ileostomy, I think in the past 12 years, I've had a single person that has needed diverting ileostomy, so really rare. And that individual really had to be hospitalized repeatedly for severe dehydration and hypokalemia, and ultimately we had to, and actually had developed complications from the hypovolemia in the setting of ischemic colitis. So at that point, we decided to do a diverting ileostomy. So, I think it's incredibly rare, but obviously there are going to be situations where you may have to offer that.
Great. Dr. Dougan, so this is about biopsies, and do you wait for biopsies before you start treatment with steroids? And can the endoscopy ever be normal in appearance in ICI colitis?
Oh, it does depend on what the colon looks like. If it has a classic appearance for ICI colitis, which is really just to say you have visible colitis, then I don't wait for the biopsies to come back, and I'll change course if the biopsies come back as something surprising like an infection. Though it's pretty uncommon if it looks like colitis that it's another cause. I do wait for them to come back if the endoscopic exam is normal, and those are the cases with microscopic colitis where I'll treat with budesonide. Then in terms of the appearance of it, what was the second part?
Yeah, so I think that was like, if it's microscopic colitis, how often does it actually look normal and you just get microscopic changes?
Yeah, it's about a third of patients. It looks normal, but it's not on biopsy. I will say, if everything is normal, biopsy is normal, appearance is normal, it's probably another cause. So we saw that, and we see that in about 20% of our patients. A good chunk of them, by the time we're done with the whole analysis, are no longer having diarrhea. So it was some acute cause of diarrhea and it's gone. But these patients can also have diarrhea from thyroid hormone elevation, and they can also have it from pancreatic insufficiency. Both of those are far more common in this population. They would be in just the general population because they're on drugs that cause autoimmune disease.
Great. Thank you. So Dr. Khalili, do you separate your random biopsies for microscopic colitis into separate jars?
It's a good question. So technically you don't need to. You can put them all in one jar, and that's okay. The only consideration is in patients that may be difficult to get them back for a full colonoscopy, and you may want to consider doing a flexible sigmoidoscopy, and then you want to have a sense about whether they have patchy disease or not. And so in that setting, you may want to consider separating it. But typically for first-time diagnosis, I just put them all in one jar. But just keep in mind that if you do a flexib, down the road, you may be missing some of these cases. But certainly you can put it all in one jar.
All right. And Dr. Khalili, our final question here on is, do you treat all your microscopic colitis patients with budesonide, or do you use conservative, just symptomatic treatment in mild disease using just loperamide, for example? Some patients with occasional diarrhea only need PRN treatment in this doctor's experience.
Yeah, no, absolutely. I mean, I think there is a little bit of referral bias here as well, in a sense that many patients that don't have symptoms, or they have very mild symptoms, they end up not even coming and seeing us. But occasionally you do see them in practice. And when that happens, I think it's totally reasonable to consider loperamide as needed. Or, they could have either very mild symptoms, like one bowel movement that's soft, or they could just have intermittent loose stool, which you can easily treat with loperamide. So I think that's totally reasonable. And actually, if you look at most natural history studies, that accounts for probably 20–30% of patients with microscopic colitis.
Well, this is one final question here. Just if you could just remind everyone what the actual biopsy protocol is for microscopic colitis. They're saying, is it 2 biopsies from each colonic segment?
So 2 biopsies from right colon, and then 2 biopsies from the left colon. The highest yield of making diagnosis is the right colon biopsies. But typically, because collagenous colitis can be very patchy, we tend to take biopsies both from the right side and the left side. So if you take biopsies, 2 bites from the right and 2 bites from the left, over 95% of the time, you're going to capture the diagnosis.
Okay. And since we have the one last minute here, I can ask this for either of you. Someone's asked, do you ever see eosinophilic colitis?
Sure. I see a fair number of people with it because I get referred a lot of patients with eosinophilic upper GI disease. I mean, it's uncommon, and it does respond to prednisone, often will recur, and I think it also responds to mepolizumab anti-IL-5 receptor, and then dupilumab probably as well, though the data actually supporting that is pretty minimal.
Do you see that isolated or in conjunction with eosinophilic?
Because I get people referred often with upper disease, I see it mostly in conjunction. I don't know if Ahmed sees it. I've not seen a case of eosinophilic colitis by itself, no.
Okay. All right. Well, terrific. That was amazing. Thank you both, Dr. Khalili, Dr. Dougan. That was terrific. We will now move into a break. So we have a 15-minute break. So we'll resume at 3:15 Eastern Time. We'll see you then.